We have Building Better Health for Self. The panel will be Andrew Vincent, Founding Director of Integra Healthcare Limited, Dr. Lisa Joels from Integra, Dr. Francisco Martinez, a general practitioner at Integra, and Dr. Andrew Shaw, who made his presentation just now. I'll invite the other panel members to come on up. And we'll transition very quickly to that final panel.
Okay, good afternoon, ladies and gentlemen. So my privilege is to be the poster boy for poor self-management for health. They were looking for a fall guy, I think, to open up a session in which we look at improving health by taking responsibility. And they wanted someone who was a good illustrator of perhaps some of the challenges that we face as human beings. And that turned out to be me. I'm not sure whether it's a privilege or a comment. So. So in theory, I should be the epitome of health. I'm relatively health-wise. I'm director of a healthcare organization. I have access to exceptional healthcare, ready access, and I think we have really good access throughout the Cayman Islands. And I should really know how to access it, given my role in healthcare. I have sufficient economic ability to be able to pay for healthcare, and I think that's an interesting question for us to discuss later on. I have middle-tier health insurance, so that's also, in theory, going to give me enough cover that I should be able to address my health. And I'm going to say I have reasonably robust lineage, and of course we can't necessarily instill that in people, but it does mean that, in theory, I should really be the epitome of health. I have a family that tend to live into their 80s and 90s, and do not seem to suffer many of the common diseases. However, then there is life. And I'm a human being. So I really like chocolate. It's very nice after dinner in the evening to sit watching a movie, eating chocolate, perhaps with a glass of wine. I enjoy my food. I think this is something that I have a lot of friends in Cayman who would say exactly the same thing. Of course, I probably don't get enough sleep because I'm a busy professional. And because I'm a busy professional, I also spend too much time in front of my computer screen. And one of the consequences of that, of course, is that I don't spend enough time in the outdoors exercising and doing things that are good for me. And so I wanted to introduce this term, health-life balance. Has anyone heard of health-life balance? Because actually we talk a lot more about work-life balance, don't we? And so I say work-life balance, everyone goes, oh yes, I know what you mean. And I think there are three dimensions to this. So we talk about work-life balance, but it's actually work-life and health. And sometimes they conflict with each other. It's a conflicting triumvirate. And if we spend more time at work, we get less exercise. Sometimes it causes us stress. It encourages a poor diet. We dive out for something unhealthy quickly at lunchtime, as opposed to really thinking about what we're putting inside us. And of course, if you're like me, self-confessed, because remember I am the poster boy for poor choices, we also enjoy more life, which can, again, contribute to a poor diet, to more indulgence, and it definitely contributes to less sleep. Of course, it adds up to less health. So for me, this became particularly important because after half a century of essentially no health problems whatsoever, not even a broken bone, no sports injuries, a few bugs, that was it, a few scrapes from falling over on a hockey pitch, I found myself being diagnosed with metabolic disease, something we've heard about over the last couple of days. And then I found myself rather suddenly under the care of the amazing Dr. Ravi in Hull City for a heart complaint that came out of nowhere. And all of a sudden, my health, my responsibility, became very, very real to me. So what do? We go to our trusted professionals. We have tests. We've just heard about tests. They measure stuff. The screening that we've been talking about over the last 2 days. There are findings in that screening even. And of course, there are explanations, some of which we understand, some of which we don't understand, and some of which we don't want to understand, particularly if it conflicts with life. And then, of course, the outcome of this discussion with our trusted professionals who we've gone to tell us how to address some of these issues is they say, well, this is all very easy. What you need to do is, essentially what you need is, you can start by cutting out that, because you don't really need that. Oh, and that's not very good for you, so you can take that out. And of course, you want a lot less of that, you want a lot less of that, and of course, if you can get some more sleep as well, then actually we'll be on the straight and narrow. The problem is that conflicts with us behaviorally. And I think we've got to do more to address some of the behavioral issues, not just the advice that says, look, just forget all the stuff you really, really enjoy, or that you have to do for economic security, because it's in your health interest. You'll be miserable. Is that such a good outcome? And maybe happiness is also part of this equation that needs to go onto that list. But I've got to realize that if I want a long life of walking on our beautiful Cayman beaches, for instance, with my wife, then I have to recognize that it's my health, and therefore it's my responsibility. And what I would say is, besides my wife, and maybe my dogs, nobody is going to love me and my health more than me. And therefore it is my responsibility, and I need to learn to behave as though it's my responsibility. I need to engage in better understanding, and mostly I need to step beyond my own excuses, and the common ones we all know. Don't worry, I'm going to fix it before it becomes an issue. Of course, you couldn't tell me that. I needed to know that, really, just before I ended up in Hull City. I'm going to eat healthier. I'm not going to be susceptible to things. I've got good lineage. I'm not going to suffer from these things, but they're all excuses, and we have to step beyond them. The other thing that I think needs addressing is the fact that I started with this epitome of health, but I can do these things. But when we're talking about the health of a nation of people, only some people have access to what I'm fortunate enough to have access to. Not everybody has the same degree of health information. Definitely not everybody has the same access to healthcare. They don't necessarily have sufficient economic ability, and of course that transfers not just in terms of access to healthcare, but also things like food choices. We heard yesterday about the CPI looking at a basket of goods, and what we heard, of course, was that all the unhealthy things stayed remarkably cheap, and all the really healthy things were becoming super expensive. Well, that's going to have a long-term impact, but it's going to have its biggest impact on the people less able to afford to make healthy choices. Many of us do not have middle-tier health insurance. That's a big issue. And I think one of the ironies is some of our basic health plans that are designed to put in place basic health actually do not invest in wellness. They simply catch you when you're sick. And maybe if we want to change the health status of a nation, what we have to do is recognize the importance of wellness and early intervention. And actually, that's more important than having the safety net. We can't do anything about reasonably robust lineage. So I'm going to throw a gauntlet down, and it's a gauntlet to my colleagues, my other colleagues in healthcare. How do we ensure everybody is at least health-wise enough that they can make good choices and understand their responsibility, that it's a collective responsibility? How do we ensure that everyone has access to trusted evidence? I think if we've learned something super hard over COVID, it's that actually the misinformation that can prevail over proper information. I mean, you can go onto Facebook, just limited to the Cayman Islands, and you can find every view of COVID vaccination you could possibly ever want to. So, of course, if you're a bit skeptical anyway, you just go out and look at the evidence that suits your point of view. But it doesn't mean it's evidence-based. It's just misinformation available. We have to make sure that we address that. We need exceptional access to healthcare. So how do we create a system that gives access to healthcare irrespective of sufficient economic ability and irrespective of insurance quality? I think we've got to design healthcare better for people that want to take responsibility. So, of course, when we get sick, it's very easy to take some time off work and go and see your doctor. But how easy is it to take time off work to go and see your doctor when you're well? And doctors tend to work 9 to 5, just like everybody else. And so maybe if we want to transform health, we have to transform access so that people can address wellness when they're able to. And how do we learn to keep people well longer? That's a big challenge for us as healthcare professionals, because obviously Andrew talked about health span. The longer we keep people in good health, ultimately the better for us all it is. So with that, I'm going to hand over to my colleagues, who are now hopefully going to address some of the questions or gauntlets that I've thrown down. Thank you. I'm going to introduce Lisa Joels. Lisa Joels is an expert in women's health as an obstetrician and gynecologist with Integra Healthcare. Lisa.
Well, thank you very much for asking me to talk. You've asked me to talk about women's health for all ages, so I thought I'd focus on prevention and what modern medicine can do to help keep us well. And when I was thinking about how to start this talk, I thought about the very famous speech in As You Like It, written by William Shakespeare. And so with apologies to the bard, all the world's a stage, all the men and women merely players. They have their exits and their entrances, and one woman in her time plays many parts, her acts being 7 ages. So I thought I'd talk you through the 7 ages of woman. The first age is the infant, but in fact there's a couple of really rare gynecological things that can happen to newborn babies. So I'm not going to talk about that. What I'm really going to talk about is being born. So the journey from the mother's womb to the outside world is the most dangerous journey that the majority of us will make, unless we're Bear Grylls or some kind of explorer. The risk of dying during the process of being born is called an intrapartum stillbirth, and this is a terrible tragedy. The risk of dying in the UK during labour and birth is 4.1 per 1,000. But the worst place in the world is in Africa, in Sierra Leone, where the risk of dying in childbirth is 190 per 1,000 births. The difference between the two places is the caesarean section rate in the United Kingdom is running at about 30 to 35%. In Sierra Leone, it's 2%. So what they lack in large parts of the third world is access to midwifery and obstetric care. And the World Health Organization has identified this as a massive problem. So we know that worldwide, 2.6 million babies are stillborn every year. That's going to add up over the next 10 years to nearly 20 million deaths, which is horrific. And what the World Health Organization has identified is women need access to trained birth attendants, so obstetricians and midwives, and even traditional birth attendants who may not have a university-level education. By identifying and managing risks antenatally and during the birth process, we can reduce the risk of stillbirth from that terrific rate in Sierra Leone down to the first world rates at around 4 or 5%. Moving on, the second age is the whining schoolgirl in the speech. So we're talking about the preteens here, and what I wanted to focus here is about prevention. So the HPV vaccine is one of the most amazing health changes that has happened in the last 20 years. So this has been available since 2006 in Australia, 2007 in the US, 2008 in the UK. And it's best if girls are vaccinated at age 12 to 13, because that's before they become sexually active in the vast majority of cases. And we know if they're vaccinated before they're ever exposed to the virus, that we get a reduction in HPV infection. So the prevalence of HPV infection is about 30% of the population. With HPV vaccine, that falls to 2%. And what that translates into is an 87% reduction in cervical cancer. That's massive. And the HPV infection causes precancerous changes. So in the UK, they did a study in 2019, and by June 2019, they had seen 450 fewer cervical cancers. Now, this has an incidence of about 3,300 per year in the UK, with about 1,100 deaths per annum for cervical cancer in the UK. So that's a significant reduction. But look at the other figure, 17,000 fewer severe precancers. Now, those severe precancers can be treated, but the treatment is invasive, it's difficult, and it can leave long-term health problems. So a reduction in 17,000. Think about the suffering that's reduced, but also think about the healthcare costs that are reduced. So what we're now finding is that cervical cancer is extremely preventable with 4 things: HPV vaccination, cervical screening, stopping smoking, and treating precancers. We now think we can treat 99% of all cervical cancers, and this is going to be almost eradicated for girls born after the 1st of September 1995. The third age, the lover. So we're talking about adolescence. So this is the phase of puberty, when those girls' bodies are going through changes. There's changes to their body, but there's also changes to their brain and changes to their emotions. And part of that is their sexuality. I want to talk about teenage pregnancy. So teenage pregnancy, including the older teenagers, so the 18 and 19-year-olds, make a massive difference to a woman's educational attainment and to her life choices and the kind of job that she's going to get. So women who don't complete their education and don't go on to apprenticeships, college, or university are usually stuck in low-paid minimum wage jobs forever. And there's a really interesting study from the United States which showed that 90% of girls who don't have a teenage pregnancy get their high school diploma and graduate by the age of 18. But with those girls who have a teenage pregnancy, only 50% of them get that high school diploma by age 22. So that's going to make a massive difference to the type of jobs they're going to get. The babies born to those teenage mothers have an increased risk of being born preterm and being low birth weight. But shockingly, they also have a significantly higher chance of dying in the first year of life. And they're also more vulnerable to accidents and behavioural problems long term. So it's not just the mum that suffers, the children suffer too. And so what we need to focus on in terms of prevention for this stage of the girl's life is preventing that pregnancy. And what we should be pushing the girls towards is long-acting contraception, the fit and forget. So that's either the intrauterine devices or, and it's usually more acceptable for the younger teenagers, the subdermal implant, which goes into the non-dominant arm. It's very easy to fit. It takes about 5 minutes in clinic under a local anaesthetic. And we are then increasing the life choices that those women had. And we'd actually heard that message earlier today about educational attainment. So the fourth age, Shakespeare describes as a soldier, and this is a bit of a battleground. These are women that are establishing themselves in their peer group, they're finding their life partner, they're establishing themselves in their careers, and also they're wanting to start a family. So this is a really busy phase of their life. So what we should be focusing on for this group of patients is optimizing their health for pregnancy. And one of the really preventable conditions is spina bifida. So spina bifida is where the spine or the skull doesn't form completely and can lead to babies not surviving. But a lot of babies that do survive also survive with a lot of handicap and a lot of problems. And it can be prevented by taking folic acid. Now, as you can see from the little picture on the right-hand side of your screen, you can get folic acid from a wide range of vegetables, delicious vegetables, but you'd have to eat 4 or 5 portions of sprouts or cabbage a day, every single day, to get the same amount of folic acid that you need, which you could just take a pill for. So we should be making sure that women are educated that before they stop their contraception, they should be taking folic acid so the levels are high in their system. But we should also take this as an opportunity to look at their wider health, to optimize their health, to help them to address the issues of weight and body mass index. And we've heard a lot about that. Some really interesting talks earlier today. We should be supporting them with diet and exercise. We should be making sure they're on adequate vitamin D. Vitamin D is going to be a bit of a theme here, and we actually heard it earlier today. And all of us in this room should be on vitamin D, because although we live in a sunny Caribbean island, I put it to you, we all work for a living. We don't go and lie on the beach. and we wear factor 50 sun cream when we do go outside. So actually, most of us are vitamin D deficient, and we should be just taking our sunshine vitamin every day. But this is a real opportunity for the woman to have a health check with her OBGYN, to review medications, to make sure that she's on medication that's safe for pregnancy if she needs that medication for other medical problems that she has, for dealing with health concerns, and for making sure her screening is up to date so that her body goes into pregnancy in the best frame that it can. The fifth age is called the justice, as Shakespeare put it. So this is middle age. Now, this is when you realize that the woman really is the linchpin of the family, okay? This is the squeezed generation. This will be the woman that's at the peak of her career, who's also managing a husband who's at the peak of his career, just starting to come into his comorbidities. She may have teenage children going through all the teenage angst, but also taking all those really important exams with all the stress that that causes. And she's got aging parents as well that she needs to deal with. So the mother is the linchpin of the family, and her health, therefore, is a key priority, and she often puts it last. So with those family pressures and her mental health issues, we need to be supporting the women in middle age. We need to be making sure that they have their cervical smears up to date, that when they get to the appropriate time according to their family risks, that they start having mammograms, and that their wellness checks include looking for blood pressure issues, checking body mass index and optimizing that where possible, and looking at their heart health and their bone health. Moving on, the sixth age, the menopause and beyond. So this is a really important time. The ovaries stop working and stop producing estrogen, but the woman's body keeps on producing testosterone. So the woman will notice her body changing, her periods will stop. Great. However, she'll start getting hot flushes, she'll start putting weight on around the middle. And the main symptoms of the menopause are hot flushes, night sweats, which lead to sleep disruption, which leads to fatigue, which leads to being exhausted the whole time. It can lead to brain fog, anxiety. There are about 34, 35 recognized symptoms of the menopause, so it's not just about hot flushes. And 80% of women will get symptoms, but the good news is only 20% of those have severe symptoms. And for the vast majority of people, those symptoms last for 2 to 3 years. There are a small number of women where it goes on long term, but for most people, it's 2 to 3 years. And the wonder drug here is hormone replacement therapy. Okay, it is literally putting back bioidentical hormones that the woman is missing, and it can tide her over that short period of time. Now, there's been a lot in the press over the last 20 years about HRT, the bad boy that's causing breast cancer. Actually, it's been badly misrepresented, and the risk of breast cancer only starts to rise after 5 years of use of HRT. And so, as you can see, if a woman's only going to have symptoms for a couple of years, we can tide her over with a short course of hormone replacement therapy, ease her into the menopause, and then take her off it. And what people don't talk about is the health benefits of HRT. It controls symptoms. They get their brains back, their brain fog goes, they're not fatigued, they're not snapping at the kids and the husband. They can make decisions at work again. There are long-term health benefits. There is reduced cancers. So there is a reduction in colon cancer and pancreatic cancer, and a really important impact on bone health, which I'll come back to in a minute. Another really important screening, though, is postmenopausal bleeding. So we need to really educate women that if they do experience bleeding after they've had their menopause, that this can be a sign of something serious. Now, there's a 10% risk of cancer of the lining of the womb, endometrial cancer, in women with postmenopausal bleeding. So that means 90% don't have it, but you've got to look for it. So they need to know that this is an important thing to bring to the attention of their OBGYN. Moving on to the seventh age, the last scene of all, old age. And one of the really important things here is osteoporosis. So there is this concept of a fracture threshold. So our bone density goes up and peaks in our early 20s, and thereafter it gradually declines. But once you go through the menopause and lose estrogen, that decline speeds up, and there comes a fracture threshold at which a small fall, a minimal trauma, will cause a fracture of a bone. The other important thing there is 1 in 4 people aged 65 will fall. And part of that is about muscle. So there's something called sarcopenia, which is where proximal muscles are lost. So this is the muscles in the arms and the upper legs, the thighs. And there can be some issues with balance and gait, which means that older people are more likely to fall. And if they fall, they're more likely to have a fracture. The rule of thirds with hip fractures is really quite shocking. So for women over the age of 75 with a hip fracture, 1/3 will recover and go home. 1/3 will recover and have to go into long-term care and never return to independent living. And 1/3 will die from their fracture. So really startling statistics. So prevention of osteoporosis is a really important thing. And you can see from that X-ray the difference between normal bone, which looks good and strong like a piece of coral, and that osteoporotic bone, where it's just fragile, and you can see that's got no strength in it at all. So how can we prevent that? So we need to educate people. We're back to vitamin D, the sunshine vitamin. It's really important for bone health. But we also need to be doing impact exercise. That's really good for maintaining bone strength. And that doesn't just have to be jogging and running, because that can be really hard on your joints. It can be just doing a decent amount of walking each day, or dancing, or doing Keep Fit. Anything that's impact exercise will keep bone health going normally. And hormone replacement also will have an impact because you're putting back natural bioidentical estrogen. You are maintaining bone integrity. And you can screen for this using a DEXA scan. It's a very simple bone density scan. So I hope I've demonstrated to you that we do have a responsibility to ourselves to maintain our wellness through our life, and that prevention is definitely better than cure. So by combining wellness checks with your GP and with your obstetrician and gynecologist, we should be looking at optimizing women's health at every stage of their life. Women should be engaging with screening programs for cervical screening, breast cancer screening, and heart disease screening. And we need to take ownership of our own health and well-being with diet and exercise and mental health awareness. Thank you for your attention.
So I'd like to introduce Dr. Martinez. Dr. Martinez is a GP and one of the founding directors of Integra Healthcare, who's going to talk about the difficult subject of men's health.
Thank you. Hello, everybody. Good afternoon. I can see this talk is not about rum tasting, because I hardly see men here. It's about health. When you talk about health, normally you see female listening. This is why Lisa has such an intelligent audience, because they take care of their health. Men doesn't take care of their health. So it's a challenge to, this is the one to advance. If you are wondering which is the weaker sex, it's not females, it's men, because they live less and they get sick more. So men are more likely to have heart disease, stroke, diabetes. Women are more likely to have arthritis and depression. Maybe depression is linked to the husband having a stroke, heart disease. And it's a problem that is not seen in one place. It's in the whole world. I practiced medicine in Spain, UK, and Cayman. It's the same everywhere. It doesn't matter the culture. There are many, many articles, papers about the main use of healthcare. All of them shows that men goes much less than women to the doctor. And there are many theories, no? The main ones of why goes back to the origins, no? When the man used to go hunting, the woman used to stay taking care of the children back in the cave, providing food, taking care of the diseases of them, and then the man came in the evening, throw there the food, and that's it. Also, this role, even with the society changed, is so inside of us that nowadays any pediatrician can tell you who goes to the doctor with the child, to the pediatrician, mainly the mother. And who goes to the gynecologist, because women start early with things like menstrual periods that can have problems. They go to the gynecologist. They get pregnant, they have to go to the gynecologist. Men doesn't go through that, so they are not exposed to the healthcare. It's Very rare. Sometimes they go with the wife for the scans or something, but they never go for themselves, no? So they don't have we don't have a culture of taking care of our health, of going to the doctor, going to the clinic. Consequences. Here you have the graphic, no? In diabetes, avoiding the doctor makes that we have more diabetes than women. Why? Because if you don't catch the diabetes early, it progresses worse. If you don't have a constant relationship with a doctor, nobody is telling you about good habits, telling you, oh, you should do this, you should go to the gym. And when you say go to the gym, normally who tells you that has no time is the man. The woman goes to work, wake up early in the morning, run, goes home, pick up the children from the school, do the homework with them, prepare the dinner, and the one who has no time for the gym or for running is the man that goes home after work and sit down in a couch watching TV, or with the friends for a drink. So heart disease, that is, apart from cancer, is the main killer in the first world. More men die of heart disease. You can see the statistics there of the coronary heart disease being the top cause of death for men. And we come back to the same. They never sit down with a professional that can ask questions and find the problems when they are starting. Because we men tend to think that many things happen and will disappear by themselves, no? We don't pay importance. So this is why I say the solution for these things is go to your GP, chat, because what you think is nothing, someone can tell you is the beginning of something. And your GP can inform you about risk factors, the ones you can prevent, can ask you, did your dad die of a heart attack, and start in an early prevention, can convince to quit smoking. Unfortunately, with women, when they copy habits from men, it's bad for them. In the 60s, women started to smoke, and lung cancer was very low in women, very high in men, and started to rise. So never behave like a man. Cancer. Cancer is the second leading cause of death among American men. I will say that among all men in the first world. The main reason for years was smoking a habit, no? Then we have skin cancer, sometimes because people has a profession that is outside in outdoors. But the main times, and you will see here in the beach, is a woman using cream, sun cream, wearing clothes to cover, and a man playing the, well, nothing happens to me. So because if I put a cream, I'm not as man as I'm supposed to be. We have the prostate cancer that is unique in men, and unfortunately in Afro-Caribbean population, can appear as early as in the 30s, what is very strange to see in a Caucasian. So again, it's a cancer that is very easy to treat. Go early, have your checkup, chat with your doctor, tell the history of your family, do a prostate exam, do a PSA. If we catch it early, we can cure it, because oncology has advanced more than ever. Now the secret of surviving a cancer is early detection. And we have the colorectal and lung cancer we talked before. Colorectal cancer, go to the doctor, tell them, again, the family history, and if not, start in a prevention screening program, doing your colonoscopy. Has been always after 50, now they are starting to recommend it after 45. And of course, if you have a dad, a sister, a brother with a colon cancer before to see where you are. If you catch a colon cancer at the early beginning, it's easy to resolve. If you wait, you can die or have terrible consequences, no, in your life. Diabetes, we were talking before, no? Women has more belly fat. Even we don't have a reduction in estrogens, we have many other reasons, no? We move less. Just taking care of the kids is an exercise, okay? And moving around home, cooking dinner, is an exercise. While you are doing that, the man is sitting, drinking a beer, watching the TV. And belly fat is absolutely associated to diabetes 2 and to cardiovascular risk. How do you prevent that? Because the secret is prevention, it's not treatment. You prevent it going to the doctor. The doctor will look at you, will give you good advices, and can check something so cheap and easy like the HbA1c that Professor Shaw was saying before. And you can catch a pre-diabetes when you can reverse it, easily reverse it with lifestyle changes. You don't need a single drug for that. But if you don't go, I have seen people here that comes when they need insulin from the beginning, and they have severe complications in eyes, kidney, and circulation. I saw a case of a poor Jamaican guy. The first time he goes to the doctor, he goes to hospital to have the foot amputated. So this can be only done by a man that see the foot destroyed and never go to the doctor. Then we have something that is only for men, no? That is erectile dysfunction. Erectile dysfunction is related with many things: age, diabetes, hypertension, medications. Can produce problems at home, no? The men can feel frustrated, suffer psychological problems, and if it is a young person, cannot have a child, no? So why don't we go to the doctor to ask him? There is a collection of drugs to stop it that works perfectly. And they work so good that I did a tour in Miami through the canals to see the mansions of the main actors and famous people. And the biggest one was of the guy who discovered Viagra. So this is how useful it is. HPV and other STIs. This is a big problem for men and for the woman living with him. So if you hide the possibility of having an STI, in the past they used to be called STDs, but we don't want to call it disease anymore because it's a stigma. No? You can get cured of many of them. So we call it now sexually transmitted infections. We have the human papillomavirus that we can get a vaccine, is indicated for men from the teenage and before a person turns 26, and in some cases, even later. The human papillomavirus can resolve by itself, but if it doesn't, and you don't catch it, and you pass it to your partner, she can have a cancer, cervix cancer, okay? And men can have penile cancer, genital warts. And in other STIs, as syphilis, you give penicillin 3-4 courses, it's gone. But if you wait, you have a very advanced syphilis that can affect even your brain, can produce dementia, can affect the nerves in the body. And then we have the life-threatening ones, no? HIV, hepatitis B. So these two can kill you. You need a treatment. And of course, you should never pass it to anyone else. So the only way to stop the spreading and to prevent the problems that these infections can produce is to go to the doctor and check it. If you had a risk relationship, be brave. You were brave to do it. Be brave to go to the doctor and tell him. He will not tell anyone. And he will do the test and he will advise you what to do. And mainly he will tell you, you need to tell your wife. No, because I have seen cases here where the wife has been transmitted the disease by the husband, by a husband cheating. So go to the doctor. The doctor is not going to go to the police, to the preacher, or to your wife. He's going to give you a good advice and a diagnosis. And he's going to tell you how to prevent it. You want to continue having this, I'm not judging, no? If you are planning to continue doing this, I will tell you, use a condom, no? Don't bring anything. Low testosterone. Now, testosterone in the last 10, 15 years is very popular, no? That picture can give an idea of something that maybe in a 50 years old is not going to happen, no? He will not look like the optimal testosterone guy, but he will need many hours in the gym. But testosterone, there has been so much controversy in the United States. You have T clinics dedicated only to testosterone. So the prevalence of low testosterone, of course, like many things, grows with age. So 12% in men in their 50s, 1960s, 28 in the 70s, and almost half of the people who is 80. In all the discussions in the last years about the testosterone replacement, when do we offer replacement? When we, in this case, Professor Shaw was telling we treat numbers. In this case, we treat patient, but we need a number, because if we don't have the number, we must be for another reason. So when a patient is symptomatic, has a low sexual drive, can have erectile dysfunction, feels tired, fatigue, is increasing obesity, is having very weak muscles, is the time that we give a hormone replacement, because this is a hormone replacement like the ones Dr. Joels is giving to the woman. Probably this is the thing that men comes to ask for more. Right? During the past, testosterone was said to produce prostate cancer. That has been in multiple studies refused. No? Testosterone replacement doesn't increase the chances of having prostate cancer. There are discussions if testosterone replacement can increase the size of the prostate. Still not clear. And there is a nice discussion about the cardiovascular, because some studies tell us that replacing the testosterone artificially will reduce the chances of having a stroke, a heart attack. There were other studies saying that you can increase it. But the problem with the studies who says that you increase it is that they were done in people over 75, whose risk of stroke and heart attack is higher by age. There are ways of replacement, injections and gels. Mainly there is an oral one, but has more side effects in liver. And I will say the main thing to control when you go to testosterone replacement is testosterone has the capacity, the ability of increasing the red blood cells. So you need to check the number of red blood cells. If they go very high, you stop for a while. And to increase the PSA. Recently, I had a patient that his PSA went to 9. We stopped the testosterone for a month, back to 1, normal. Why? Because he was overdosed. He decided by himself to apply twice the amount of the gel I prescribed. So, because he was feeling that he was going to the gym and he was feeling stronger, because testosterone makes you feel that, no? Makes you feel generally better. Depression. Depression, again, we are going to the stigma. No man likes to say he's sad, he's going through a bad time, this is for women. And it's not true. It's real that women suffer more depression than men. There are many reasons, some of them physiological, other ones cultural, because women are not treated as sane as men, not yet. We are still trying. But men experience depression. The ways how they show, they are not going to tell. Normally, they don't tell the wife of the partner, I'm sad, I don't want to do anything, I would like to stay in bed. No, they get irritable, anger, they will blame the partner of anything. So it can become a problem of even, in extreme cases, no, domestic abuse. So we need to keep the man away from depression. How? Go to the doctor. There are fantastic medications to put in 3 weeks the mood of a person in a normal level. And chatting, chatting with your doctor, and telling everything you are feeling to try to control it, anxiety, depression. So what I recommend, there are many females here, is that your partners, when you see them behaving like that, recommend them to go to the doctor. Maybe there is a depression behind. And it can be treatable as 3-4 weeks to see the results. And this is the thank you for listening to me, okay?
So I'm learning something. I think I've actually got a pre-optimal testosterone body. It's got nothing to do with my lifestyle after all. So I'm going to welcome, actually, before I welcome Professor Shaw back up, I want to really ask a couple of questions. So do you get the impression that from a healthcare perspective, we actually have a lot of the answers in terms of knowing what to do? Yeah. So who then, this is kind of a leading question because I've kind of set it up, but do we have a healthcare issue or a behavioral issue then in addressing our health? Yeah, so yeah, it's a behavioral issue, isn't it? So I'm going to invite Professor Shaw up to talk about, actually, although he's going to talk about technology, I actually think he's going to talk about behavior. So Professor Shaw.
Let me change the slide deck. So I think many of the stories we've just heard have the opportunity for measurement and my technology to make a difference. So if you are a man, maybe it's easier for you to make a measurement at home and come up with something that says you're depressed or your testosterone levels are falling. Maybe it's easier for you to do that on your own. Maybe it's easier for you to then take a teleconsultation. Maybe we can nudge the boys into doing some better healthcare. But it is important that you get the right tests. We need to learn to develop the right tests. They can be expensive. They're going to go off to the laboratory. They can be, yes, not point-of-care tests at all. And they are, in my mind, some of them are really quite bad with not giving the right answer. But now, I'm going to give you the right answer. Not just here, but everywhere. In the bathroom, in the bedroom, wherever you make the test. So fully quantitative, big profile of what's going on. I think it's really important to understand, if you're doing hormone replacement therapy, that you knew what your hormones were before the therapy was required. That might make the transition better. So let's profile things properly. Let's use what the science can do to make the doctors, empower the doctors to make better clinical decisions. So what? What if the consultation is anywhere? I think it's really important that we get used to nudging different types of behavior. The consultation can be in Africa. Teleconsultation will happen everywhere now. I think my children will probably go to their doctor via video call much more frequently in the future than we attended. What about doing something in the ambulance? The best first decision means you can do the test. Maybe when you pitch up at the ambulance at the hospital, the ambulance has already made the test for you. They've made the diagnosis. The data have come back from the ambulance to the hospital. Everybody's ready for you. The right team is waiting for you. The decision's been made. In the emergency department as well, I think blood tests are very rarely available in time. Some of them are, but I think more of them can be done. But I think in the GP consultation, which in the UK is only 11 minutes, you've got to get in, get your test result, get the diagnosis, and get out again. The care pathways are tricky, but all of them require, I think, the ability to give the right test result when you need it at the right time. And it's complex. You've seen this idea that I have, the idea that you can make the test at home, and I can check that it's a good one, check that you did the test properly. Then I've got the data in the cube, and I can give that to the doctor properly, and the teleconsultation then becomes properly informed. Maybe the boys are going to be better at doing it. First of all, it's a toy. Boys and toys work quite well. Expensive toy, even better. So maybe we can play with our toy. Maybe the gamification is an interesting motivator. Maybe we can do what's more, do much more through the idea that the data go into a game and you start to play it. Maybe these are different. Maybe even a testosterone-ridden game where you can encourage the boys to participate. So, what we seem to be unable to address is this massive problem around the globe. I don't know whether I've got the answer yet, but maybe I have a chance. Maybe if you can see the right data at the right time with the right information, maybe there is a chance to do this. Why not simply address what we may do, what we can do, and at least not cost us a fortune? Let's have the test at a reasonable sort of price. Let's do it frequently. Let's do it when you want to do it. Let's have a go at this solution to the problem, which is an amazing inability to get the test results when you need them. So the bias is all behavioral. We picked it up. This corner of the room shouted out behavioral. You're absolutely right. There are lots of problems here associated with the availability of the test, the limited attention span we have. You want to go into the GP consultation, you now want the answer. Gen Z, Generation Zers, are going to want to sit on the sofa, mail away their blood test, get the answer back to their app without having to go anywhere near the doctor if they don't need to. But I think if you can order the blood test and get the result in the way that you order the pizza, then there's a way of getting the behavioral activity on your side. I do think learned helplessness bias. I mean, I think there's some questions about boys needing to be taken to the surgery by their wives. I think there's something around that we can change again, maybe empowering with a different way of collecting the data, a different way of, if you're involved in the process of collecting the data. And these things then become interesting ideas. So lots of different biases, this is 9-dimensional here, that change by having a different way of receiving the data and giving the data to you when you need it. So let's revise the paradigm, let's change, make something different. Patient attends wellness, for a wellness screening, already that's novel. Some people with executive benefits get wellness screening. The big panel of blood tests are taken annually. Very rarely does anybody else do that. Maybe you would do that if it was possible at home. Doing a chip once every 3 months or something, once every 6 months in the bathroom at home, not an amazing problem. So a wellness screen, find out what's normal for me, find out where I am now. And you've just heard all these stats that we've been hearing about the diseases in both boys and girls. Just get worse with age. As you get older, you just experience life more. You pick up mistakes, you pick up exposure to sunlight, you pick up exposure to the environment, and age just ticks on. So if you know what's good now, then you can begin to see what happens as you get a bit older. Diabetes panel. When you arrive at the consultation commences, you've got the data in the hand, you know what's normal for you, you know what's on your records, maybe share that with your blockchain. The results are identified from the fatty liver disease, consistent with the diabetes, and then you get an immediate diagnosis. You're in the door, you get the answer, or you make the measurement at home, you get the teleconsultation, you get the answer, and off you go. That sort of need to get things moving, to get the world working on your side is quite strong. All this within a single consultation, why not? If you turn up in a really bolshy mood and want antibiotics, I can say, no, the test doesn't allow that to be prescribed. Patients comply with antimicrobial resistance stewardship. They understand that if you don't get the test, you don't get the antibiotics. So I think we can change this. This is the paradigm. This is what we need to do. Get the answers that you need when you need them. So we can begin to eliminate some of these biases at the top here. And we can begin to eliminate, in fact, all of them. We're going to be less defensive about things. We're going to be more acceptance and discussion because the data are there. It's going to be quite hard to say no to something if it's there. What if you are a man and you're depressed and yet you won't tell anybody about it? But the idea of a biomarker panel for mental health might point to depression. It's going to be hard to deny at some point, to deny the test result. So maybe we can get over some of these acceptance discussions. And we can begin to trust the immediate results as we get them. All of these things may be addressed by just having the right answer at the right time for you, nudged maybe by some gamification, nudged by some testosterone reward. All of these are really interesting ideas that might change the way we get the paradigm of the new paradigm right. So, from the dark, we know that so many people, in that Mexican study I showed earlier, so many people have no idea whether in some pre-diabetic state or some pre-NCD state. From that ignorance, by a simple set of tests, routinely changing the culture a bit, leading to intervention, all in a single consultation, and we have to eat more of these lovely vegetables. So I think that sets you up from what's the problem, doc? Something's wrong there. What do I do, and how do I fix it? Even better if we know a bit about you and what's normal for you and where you've come from, so know what the changes are. So ignorance to intervention in a single consultation, I think that's where we need to be. This is really exciting. If there is a way of getting out of something as complex as type 2 diabetes by some simple testing, by a teleconsultation, by a nudge, by a gamification, by a colleague that you're competing with, by a class in which children are competing with one another, why we're not engaged in some sort of route to remission that would result in elimination or for even young children, type 2 diabetes. And if you've got type 2 diabetes beginning at the age of 8, there's a boy in my son's class who is nearly spherical, and he really needs to work much harder to get his weight under control. And I think if he could engage in a game, nudge him to be a bit more engaged in the process, then we stand a better chance of making a difference. So, lots of benefits globally, benefits that we're not going to see in the Western world, but globally, telehealth, no travel, best possible management, multi-professional approach. We can engage all sorts of different people in the process of managing the condition as it presents, from the doctor, the physician, through to the diabetes nurse. All of them are now empowered to make the measurement and make the transition. All of this is self-reinforcing. Maybe you feel better because you're doing something about your health. Maybe if you make a quiet measurement somewhere and see it's going better, maybe you feel a bit stronger as that manhunter again. So all these self-reinforcing processes, I think, are encouraging. But on your own terms, with the right number in your hand, I think these are interesting ideas. So improved access to healthcare internationally, into every corner of the planet, into every nook and creek, every restaurant, every hospital. In all of these places can now have proper diagnostic accuracy. It's you as well. The personalization is critical. That allergy profile I showed earlier, the immunity profile I showed earlier, you just need to know where you are, and then you can do something about it. I think there's a lot of data going to get collected. A lot of data about you will be collected. And I think we'll have to learn to do some AI machine learning. I think that will be really exciting. It's not there yet, but I think it has the opportunity to make a difference. Diagnostic and predictive algorithms can then be invented, giving the doctor decision-making at the point in the ward at night when they've done 55 patients, they're a bit tired, they're under stress. Maybe the AI can help make some of those mistakes less likely. And how many diseases could we tackle at once? Can we tackle all of them? But you've got your NCD with your COVID infection, you've got your NCD with your food allergies. Everything is linked in this really amazing piece of chemistry that is our bodies. So that's my conclusion. That's where I think we might take healthcare.
So thank you very much, everybody. We wanted to have a little bit of a discussion about some of these issues, because obviously this is about tackling things like NCDs, unhealthy behaviour, fixing me, a variety of other healthcare challenges that we have. So can I just start by asking if there are any questions of any of us at this point, or comments? So I want to open up a question for Dr. Martinez. So one of the things that Andrew proposed was being able to go from, you've finally been dragged to the doctor by your wife. My wife is somewhere in the audience. She knows this only too well. And you sit down and you manage to run a test, maybe on Andrew's machine, and the information suddenly is at your fingertips while you're sat there with the individual. What do you think is the impact of being able to have a conversation before that man has a chance to run out the door that actually deals with perhaps the health issues that the information is giving them? How does that change your approach to? There's a mosquito here. I'll have another disease in a minute. How does that change your approach to managing us difficult men?
Obviously, if you have the results immediately, so I mean 7 minutes or 8, 10, you use that time of waiting for the results to continue the education of the patient, and before he's running away, that is what normally they do, you give him the results, the treatment if needed, or the advice. What normally happens is that they do the blood test, and in 3-4 days, even 2, you call them back, and they are at the office. So in the last times I have changed. When I see something that I don't like in the blood test, I don't call. I tell the nurse to book an appointment, a free appointment. I don't charge for it. But I prefer to have the person in my face, so I can use different techniques. No? With a woman, it's very easy because they follow the instructions normally. With a man, you need to scare them. And you need to scare them in a way that is important for them. No? Normally, sometimes I say, okay, you are an immigrant in this country, you are working here for saving money for going back to Jamaica, Philippines. Do you want to go back in a coffin and your family enjoying the money? Or do you prefer to come back in a nice plane and enjoy the money there with? If it is a local, I say the same, no? Normally I use an example. If you follow this, you will be enjoying the beautiful Cayman many years. If you don't follow this, you will be enjoying Cemetery Beach, that is beautiful from outside, not from inside, right? Because they don't see many people. No, there is a problem with when people has no education, it's more difficult to understand, no? And you need to be clear with them, because if not, they don't do it. I have prescribed medication for diabetes, and they take it for a month, and that's it. They don't come back. The next time they come back, they cannot see. I was a very good friend of Dr. Manny. He used to tell me that he presented in a congress in Miami of ophthalmology. And in any place, normally for glaucoma, it's a disease you prescribe drops, and if they don't work, you do the operation. In many men, he used to do the operation as a first because he knew he was giving the drops and they never come back until they are blind. So the approach, I know if I take out any of the women here and if you don't use these drops, you will be blind. The first thing you think is, what are my children going to do with me blind? And then you appreciate to see it. A man forgets, and the next day is something very sad, but it is what it is, no? And depends also a lot on the education. So education is super important.
Many of us have obviously, well, all of us have had older relatives, of course, at some point in our lives. It makes us universally the same. But a question that I wanted to... Oh, there's a question down here. Let's do this first. Mm-hmm.
Mm-hmm. That being said, one reoccurring theme that people have been talking about, and even since yesterday, has been obviously pre-screening, prevention, shall I say. And as you alluded to in your presentation earlier, with taking time off when you're not sick to prevent you from being sick. One of the things that I wanted to ask the panel is with respect to healthcare, with respect to insurance, with respect to being proactive, being preventive. Normally, that's not covered until you are sick, until you have to go to the doctor. So where do you see that changing? Again, like you said, education is key. Taking those incentives, not being afraid to go when you're not feeling well. But again, where do you see that changing? Because it's a reoccurring theme, and everyone has mentioned it. Everyone said, you know what, go get checked before you get sick. Go before, you have to. But the thing is that we don't really have that luxury to do that because you're not covered. Your insurance won't cover it. The healthcare won't cover it unless you actually have a need to go there. And then God forbid if you actually do have something, then that just gets the ball rolling again. So I wanted to ask the panel, what can we get from this or taking from this, along with the Ministry of Health and Wellness, along with all of the other, with the Health Services Authority and Doctors Express and hospital and all of those people, where can we actually come to that crossroads where you would encourage people and maybe even compensate them for taking the initiative and going to get pre-preventative care prior to this. And similar to what Lisa had said, and with respect to her presentation, numbers don't lie, stats don't lie. And we see that, women that are getting HPV care and born on or before 1995, it's almost all gone. But again, that's preventative. So it's taking that initiative to do that. So I just wanted to get your thoughts on that. And I am hoping that out of this, and this is why I love these type of conferences, out of this, that people will recognize this is an ongoing theme. How can we address that, and how can we encourage people to go, go get checked before you need to get checked, is what I'm saying.
Thank you. I think you're raising an incredibly important issue, and I'm going to make a couple of comments, and I'm going to hand over to Dr. Martinez for a couple of comments as well. I mean, first of all, I think there's some good news. I think there's a growing recognition that if we never address wellness, we will increasingly be unable to afford sickness. And I know that's recognized by the ministry from, obviously, Ms. Turner's introduction yesterday and some of the talks that we've had, which is good news, because if we're not even talking about that issue of how do we focus on wellness, then nothing is happening in wellness. I think obviously making the costs of wellness lower is part of that, because sometimes that's seen as prohibitive. I think we have to reset our normal behavior. Our normal behavior is to wait until we're sick. And so in some respects, we could say that maybe the structure of the insurance policies that we have is a function of what's our long-term historic behavior. Maybe we've all got to change that. If we were demanding of the insurance companies that wellness was a heavier focus, and we would go and use it if they did it, they're trying to cope with the back end, which is the ever-increasing disease burden. And of course, they're faced with what I think is a real Hobson's choice. Because as the disease burden goes up and the costs of healthcare go up, then obviously what they have to do is raise the price of the policies. Arguably, there's even less room in there for wellness stuff each time they're carrying a bigger disease burden. But there's another problem as well. Because of our economic circumstances as individuals, the more the premiums go up, It's not that we do without health insurance. We go down in levels of cover, and actually we end up with less and less wellness cover. Because obviously something like BritK Absolute Premium has lots of wellness in it, and the BritK Chic, and this is not a comment about BritK, just in case anyone was thinking, but the BritK Chic plan has relatively low wellness cover. So I think there's a lot of complex issues here, but I think there is a focus on it, and we are starting to see a shift.
Humans, we tend to think in the short term, okay? When you have a job and you are the CFO of an insurance company, of any company, okay, they will check your economical results every year. And increasing the wellness is not going to give economical results in 3 years. It's going to give it in the long term. So the only way I see to do it is to change the mentality. Maybe, I always thought sunny ideas, no? If someone doesn't use the wellness in the policy, the next year he has a extra cost. So you force the people to use the wellness. To have a basic wellness is not so expensive, because to have a visit with a doctor, check for cholesterol, diabetes, high blood pressure, we are covering the main reasons that are making HSA to have dialysis. That is super expensive. We are covering the main reasons why the people has a stroke being 50 and has a disability. But to make someone that is under pressure every year, like a CFO, over the results, thinking in results in 10 years, we don't see the benefit of prevention in the short term. So we should focus more in wellness prevention than in sickness. I don't say that we don't have to cover sickness. We need to. But maybe in 20 years we are having less sickness because the people is better care from the 20s. And when they reach 50s, that is when things happen. They are not smoking. They try to drink moderately. They know how is their cholesterol, blood pressure, and diabetes. And they do some advice about cancer. And the woman do the pap smears, the mammogram, the man starts doing the PSA, the smokers do a low-dose CT scan. But the basic that you have to do when you are 30 is so cheap and easy that we cannot afford in the society to not have it done.
Thank you. We've got time for one more question. There's a question at the back.
Yes, just a comment here. As a primary care physician, and I am seeing patients who come in, the thing is, one of the things I think that is missing here is health promotion. We have to make patients know that they are responsible for their health and they have to be a partner in their health and wellness, okay? I'm a great critic of the insurance companies that give you 2 visits per year, especially if you have a chronic disease. But guess what? If you took your responsibility for your health and know that, well, I'm going to go to the doctor, I'm going to have my screening test, I'm going to see what is wrong with me or what is not wrong with me. The doctor will write you a day sick leave, which is covered by your company, okay? You don't wait until when you're not feeling well before you come. If you only have 2 visits per year, you say, well, at this time, the 1st of March, I'm going, on my birthday, I'm going in, I'm going to get all my screening tests which are allowed me. But some persons do not believe that they really are partners in their health and wellness. And they're waiting until they're ill to go to the doctor for someone to tell them that there's something wrong. I think we need to do more public service announcements and more health promotion. Thank you.
Thank you very much. I think that's I mean, I think it's a comment that we all recognize, and I think it's not just, obviously, the health promotion, it's also the reliable health information, because we're all subject to health influence and health information from so many sources, and it's not always right. And maybe that's a challenge to us as healthcare organizations and public health systems, is in increasing that so that people learn to trust the information that is actually helpful to them. I do think perhaps my wife paid you to remind me about the self-responsibility. And of course, that's really where I want to leave things off this afternoon, is that for all of these things, many of these things take time to change. But as individuals, we could take a decision today to change something that we're doing tomorrow and start to have an impact on it, whether it's a simple visit to an OBGYN or to a GP or getting a test for something that you think, well, you know, maybe I've got a bit of a family history around this, maybe it's better to know than not know. But it starts with a decision from self. And I think that's the principle that we really wanted to get across, is better health for self. Starts with self, but it's going to involve actually a whole system getting behind that principle if we really want to change it for a nation. Thank you.
Thank you very much, Andrew. Also, thanks to Professor Andrew Shaw, Dr. Lisa Joels, and Dr. Francisco Martinez. Thank you very much for that enlightening panel. This brings us to the end of today's proceedings. We'd like to thank you for being here, and we look forward to having you join us tomorrow as we wrap things up. Have a good evening.